having trouble.
Each year, 1 in 100,000 people in the United States are diagnosed with an acoustic neuroma brain tumor. And since 1981, the Acoustic Neuroma Association has been offering patients and their caregivers the support and information they need to make educated decisions and engage with a passionate community of peers. The ANA provides the most comprehensive, up-to-date patient materials, access to in-person and virtual support groups, informative webinars, and an active online community. The ANA also provides funding for important medical research and studies and connects patients to the medical community. The Acoustic Neuroma Association is the premier resource for the acoustic neuroma community, now and for decades to come.
Hi, we are back again. We're here for our third presentation in our ANAwareness Week 2021 series. We're very excited to have you with us again today and throughout the week. We want to thank the Mayo Clinic for putting together a great series of presentations for us. We are very excited to welcome Dr. Maria Peris Celda, who is going to talk to us about the anatomy of acoustic neuroma or vestibular schwannoma. So she is going to do a presentation called Understanding Acoustic Neuromas, a journey through the key anatomical structures. And Dr. Peris Celda, I will let you introduce yourself in just a minute, but I want to let everyone know kind of how this works before we get started. So just for everyone attending, you are in listen-only mode. You can, if you have questions during the presentation, if you're attending in the webinar, there's a questions box in your toolbar, and you can ask questions there. If you're on Facebook, you can just put it in the comments section. We are monitoring both of them. I'm adding captions to the presentation right now. So now that you should see some captions at the bottom of the screen. I'm sorry, I forgot to do that earlier. If you don't see them, there is a captions button in your toolbar that you can press to activate those. And also we're recording the presentation. We'll put it on our landing page, our ANAwareness Week landing page in the presentation section sometime later today or tomorrow. And then it will also be on our Facebook page, and we'll add it to our video library. There's lots of ways you can get involved in our Awareness Week this week. Just visit our website at www.anausa.org and click on the homepage slider. There's a button there, and that'll take you to the page. So Dr. Peris Celda, welcome. Thank you for attending. Thank you for coming and for talking to us today.
Thank you very much. It's an honor for me to be here. Thank you for the invitation. So I'm one of the skull-based neurosurgeons here at Mayo Clinic, and I take also care of acoustic neuroma patients in surgery. And I would like to share with you today, as part of the ANA awareness program, what we know about the anatomy of these lesions and what is normal anatomy and what happens when you have an acoustic neuroma and how that distorts the anatomy and provokes the symptoms. So I think this is going to be very important to understand what happens with an acoustic neuroma, or after surgery and during surgery, what we face with and where the potential complications could be. And I also would like to really quickly go through the main approaches that we have to remove acoustic neuroma surgically. And we're going to see that with in a presentation with some anatomical dissections in specimens. So I'm going to share my screen now. And let me just put that in presentation mode. Are you able to see the main screen?
Yes, we can see
It's
that.
phone-based?
Thank you.
Okay,
Mhm.
wonderful. So I have no disclosures that are related to this topic, and I would like to. I also have a surgical anatomy laboratory in which we invest time and a lot of resources, and we have research going on new ways to perform the approaches and new ways to find the relevant surgical anatomy in these lesions. So this is a great illustration from two of our colleagues, Dr. Carlson and Dr. Link, who recently published a very nice and comprehensive paper about vestibular schwannomas in the New England Journal of Medicine, which is one of the most important journals in general medicine, basically. So this is a view from above of a skull with the cerebellum and the brainstem. And this is what happens with an acoustic neuroma. So as the acoustic neuroma grows from the hearing and balance nerve, it starts by growing, and if it gets to this size, pushing on other structures that are normal. Number one, it can push on the brainstem, it can push on the cerebellum. If we look at the other side that is normal, and the really large tumors can compress on the fourth ventricle, which is one of the main outflows, or the main outflow of the cerebrospinal fluid in the brain, and that can cause accumulation of fluid above that, and so what we call hydrocephalus. So apart from coming from the eighth cranial nerve, it also compresses, and this is why it can affect the seventh cranial nerve, and is one of the main risks in surgery as well, because it really, like the hearing and balance nerve, so the eighth nerve that we call it, and the seventh cranial nerve, which is the facial nerve, they run through the same bony channel. And that's why this can be affected with acoustic neuroma. It also can push on the nerve, the trigeminal nerve, that is this one here, which really gives sensation on that side of the face. So as part of the direction of the neurosurgery and otolaryngology surgical anatomy program, what we do here at Mayo Clinic as well is another research. The research part of this is in the surgical anatomy laboratory. Our residents and fellows and international fellows and national fellows work countless hours to figure out in anatomical specimens how we can improve the surgical treatment, what we need to know about the anatomy of this area to make the surgeries more accurate, gentle, and safe. And by performing that, we've published a number of atlases in anatomy. We have published many surgical anatomy papers, and we are also not only doing this in anatomical specimens in the laboratory, but we are also putting that together with 3D virtual reality and also 3D printing, not only for acoustic neuromas, but also for other tumors as well in the skull base. So this is a view of the back of an anatomy specimen in the laboratory. So we can see one of the main veins that we call the sigmoid sinus and the transverse sinus. So the acoustic neuroma, if this is the cerebellum, this is a view of the back of the head. This is the ear canal. We have removed the earlobe right here. So this is one of the main approaches that we use for vestibular schwannomas, what we call the retrosigmoid approach. And this is behind this really big vein that we have. And if we do an approach through the mastoid, we go in front of this very big vein. And then when we do an approach to the middle fossa, we go in this area. So this is a view of the brain. It's a brain view from in front of us. So this is a view of the brainstem that we have here. And just to point out how many different vessels and the nerves we have here. So if we start, this is one of the biggest arteries that we have in the brain, that's called the basilar artery, and the vertebral arteries. And they give some other branches that are going to irrigate the brainstem and the cerebellum. So the acoustic neuromas, they come from this small nerve, which is the 8th cranial nerve, which is the cochlear and vestibular nerve. That's why they cause hearing loss. That's why they cause tinnitus and dizziness. So we've looked closely here, and this small nerve here, that's the facial nerve. And we can see that this nerve, which is the hearing and balance nerve, where the vestibular schwannomas arise, is extremely close together, basically with the facial nerve. So we can see on the other side, this is the facial nerve, this is the vestibulocochlear nerve, which is where the tumors arise. This small nerve here is quite close to it, and is the nerve that goes to the eye and moves the eye outward. It's called the 6th cranial nerve. Then close by, we have the nerve that gives not movement, but sensation to that side of the face. So if the vestibular schwannomas grow significantly, they can affect your facial sensation, either in the form of pain or in the form of numbness. And then we here have other little tiny nerves that are the lower cranial nerves, what we call them, and they take care of your voice as well and the swallowing. And then here is the 11th cranial nerves that takes care of elevating the shoulder and so on. So this is the area that we call the cerebellopontine angle. And that's why these tumors are called tumors from the cerebellopontine angle. That is the angle between the pons or the brainstem and the cerebellum. So if we look closely at that area that was we looked at in green before, we have again, this is the facial nerve that is very closely related to the vestibulocochlear nerve or hearing and balance nerve. And then we see here that there are a lot of vascular loops. Those are important arteries that we need to preserve, of course, during surgery. And these are the lower cranial nerves. This is a magnified view of the trigeminal nerve that really goes and gives sensation to the face on that side. And this is the small nerve we talked about that was going to the orbit and to the eye and moving the eye outward on that side. So this is the right side of the brain looking from the side. And so we look very clearly again at the facial and vestibulocochlear nerve. So when the tumors grow, as I said before, they can impact the function of the lower cranial nerves, also the face, and also the movement of the eye, apart from the facial and hearing and balance function. So this is a little complex view here, but I'm going to explain. This is the left side of the face. So this is the eye. So the eye is here. This is the back of the head. And we are looking at the inner ear right here. So this is a cut of the brainstem. So we have again the nerve that goes to the sensation of the face, not the one that moves the face, the one that gives sensation. But then here is the bony channel where the hearing and balance nerve and the facial nerve go together. So this is what we call the internal acoustic canal. So the nerve, after going through, and this is the same dissection in the back. So we are looking at the head like this. So this is the brainstem. So this is where the hearing and balance and the facial nerve go together. And here we have opened this bony channel where the nerves run. And this is actually the inner ear. So the balance nerve goes to this part of the inner ear, and then the hearing nerve or cochlear nerve goes to the cochlea, which is on the other side. So when the tumors grow, they grow from these nerves, and they can push posteriorly through the brainstem. They can push up towards the nerve, the trigeminal nerve that gives sensation to the face. And then they usually have a part that goes inside the internal acoustic canal towards the inner ear. So now we are looking at the back of the head. And this is again the nerves that go here. It's the same dissection. Those nerves go to the hearing and balance apparatus, the inner ear. So they go to the cochlea, which is the hearing apparatus that goes here, and they go to the balance part that is the labyrinth. So here we have the facial and then the cochlear vestibular nerve. So we have depicted the a supposed vestibular schwannoma that would grow, especially in this area, and what it can affect. So if we look at another view of this, if we turn the specimen, and this is the eye, and this is back of the head, we can look at the bony channel that we opened here before from above. So this is what we call the internal acoustic canal, and we again have the labyrinth or the balance apparatus here and the hearing or the cochlear apparatus right there. And the nerves run in this very small channel, and it's the facial nerve and the hearing and balance nerves. So the vestibular and cochlear nerve right here. If we look at the bony channel again, where typically the vestibular schwannomas want to go into, and some of them are just inside that channel when they are very small, then we can see the facial nerve that goes and moves the face. And then the vestibulocochlear nerve that goes to the inner ear that takes care of the balance right here. And then the cochlear nerve that goes here to the cochlea. So this is, I'm gonna go through some of the approaches. This is an approach that we call middle fossa. So this goes above the ear. There are different incisions that can be done. This is one of them. And then it goes through the muscle. And then we have to take a little piece of bone out. And then what we find is between the brain and the bone, we can open this channel. And these are the tiny nerves that we saw before in its bone channel that is called the internal acoustic canal. So here, of course, there's no tumor right here because this is an anatomical specimen, but we can see the nerves here in the back. So if there's a tumor, it can be removed by looking at the nerves and dissecting that from the nerves. Then another approach that can be done is called the retrosigmoid approach. That is behind the ear. So there's one that goes just posterior to the ear, and then there's one that goes just behind that big vein that we saw earlier. That is called the retrosigmoid approach. Again, there are different types of incisions that can be done for this. This is one way of looking at it, but basically it goes behind that vein that we talked about, which is the sigmoid sinus, and here is the transverse sinus. So we usually remove a small piece of bone, and then we enter the dura. This is the cerebellum, which is the part of the brain that we saw earlier. And that between the cerebellum here and the bone here, we are looking at all the nerves that we saw before. So this is basically a surgical type of picture. Of course, this is not a surgery. This is an anatomical specimen again, but we can see the vestibulocochlear nerve. So if this had a tumor in here, if there was a tumor in here, it could be from this small to just occupying everything here, which is what happens with really large tumors. So the facial nerve is really just in front of this, so we cannot see it, but it's just in front of these nerves. So this is the trigeminal nerve that really gives sensation to that part of the face, not the facial nerve. The facial nerve is just in front of this. We don't see it right now. And these are the other small nerves that we talked about, the 9, 10, and 11 cranial nerves that are called the lower cranial nerves that are around this area as well. So when we, in surgery, we have to open this bony canal posteriorly, and then we see here the facial nerve and the vestibulocochlear, where the tumors arise. There's a little nerve that runs from one to the other that's called the nervus intermedius. But what I wanted to show here is that the tumors usually have when they can be very small and just arise here in the canal, or they can be progressively bigger and have part here and part inside of the internal acoustic canal. So there's another surgery that we can perform, and this does not have the possibility of preserving hearing. That is a translab approach. And that goes, instead of here posteriorly, the incision is usually this way. And we go through the bone of the ear, that's called the mastoid. So this is the big vein that we saw earlier, called the sigmoid sinus. So earlier in the retrosigmoid approach, we performed the craniotomy just posterior. In this way, we go basically through the bone of the ear. This is the inner ear, this is the labyrinth. So if we remove this, we perform this when we don't have any hearing left before the surgery. So if the patient has complete hearing loss, in some cases are really good for a translabyrinthine approach. And when we open the dura and remove this is the facial nerve that we see here. So this is exactly how this continues. Right there, after removing the labyrinth, we see the facial nerve right here. So this is basically all the course of it. So we see again the lower cranial nerves here, the trigeminal nerve that gives sensation on the face right there, and the facial nerve is right here. These are the divided vestibulocochlear nerves. So we had an acoustic neuroma here that would be arising from these little nerves here. So this is what I wanted to show you about the basic anatomy of the acoustic neuroma. I hope this can clarify some of the what happens when you have acoustic neuroma or after surgery, or what the risks are with the surgeries. And I'll take any questions at this point, so I'll be happy to answer them.
Okay, thank you so much. That was really interesting and very informative. We don't have a ton of questions, but we had one that came in that was regarding tinnitus. So saying that the patient said they had objective tinnitus, which I understand is can be heard, I guess, by the person observing with a stethoscope potentially. So is there a difference with that and regular tinnitus, and how an acoustic neuroma might affect that or cause that?
So there's really not a very good anatomical explanation for these differences in tinnitus.
Mm-hmm.
So I would say that everyone is a little different, and I don't have a good explanations for why some patients have more or less severe tinnitus. Some of them have tinnitus, some of them don't have tinnitus.
Mm-hmm.
And also, like, the results in surgery regarding tinnitus are very variable. So I cannot really pinpoint to a certain anatomical structure that has been more or less affected.
Okay. And we have a question about, we hear about the three different approaches to surgical removal, the translabyrinthine and the suboccipital and the retrosigmoid. This patient had a retromastoid. Is that different? And is that rare?
No, it's a different way of saying the same, basically. So the retrosigmoid approach is also called retromastoid approach, and it's also called suboccipital approach. So they're really the same, different names for the same approach.
Okay. And is there an easier recovery generally between the middle fossa or the retrosigmoid for the patient? Is it dependent on the size of the tumor or anything else? How do you as a surgeon make a choice between those two?
So basically, it's number one, we have to look at symptoms.
Mm-hmm.
So basically, if there's not complete hearing loss and one of the goals is to preserve hearing, then we would not do a translabyrinthine approach, because just because of the approach, the hearing will be completely gone. So if we attempt to preserve hearing, then I would say, for medium to large tumors, I would say that the retrosigmoid approach is what we usually choose.
Okay.
And for patients who have complete hearing loss and they have a tumor that has certain anatomical features, then we may choose the translabyrinthine approach. It is said that there's a little bit easier recovery usually with the translabyrinthine approach, but that's variable, patient to patient as well.
Okay. Okay. And we had a question. A patient has numbness on their tongue on the left side. So if that is a symptom, does that mean that the trigeminal nerve is involved?
So there are multiple ways in which the trigeminal nerve can be affected,
Mhm.
and if it's on the size of the side of the tumor, and the tumor is large enough that is compressing the trigeminal nerve in MRI, that we can attribute that to usually to the tumor, but would be different case to case, and I would, it's difficult to evaluate without looking at the particular MRI, but it's certainly a symptom that can appear if there's compression of the nerve.
Okay. And you talked a little bit about the different approaches and what nerves are more visible with each different approach. So with the translabyrinthine, which nerves are most at risk with that approach?
I would say that,
I guess,
I'm sorry?
or most difficult to see, I think.
So it depends a little bit on your particular anatomy. It depends on the anatomy of the jugular vein as well, and the sigmoid sinus.
Mhm.
Sometimes if the sigmoid sinus is really large and it's really high, you can have a little bit more difficulty in looking inferiorly at the tumor, but everything depends on the size of the tumor and the particular anatomy of the patient. So we really have a multidisciplinary team. We look at it together and kind of decide with the otologist what's the best approach for the patient. I would say that the risks basically for the nerve, as long as facial nerve preservation, I think it's quite similar between one approach and the other.
Okay. And if a patient still has hearing, are there reasons that you would not perform hearing preservation surgery? Other reasons outside of that are separate from the hearing?
So every case is different, but I would say, as a general rule, if there's serviceable hearing, I think a retrosigmoid approach is usually chosen for that.
Okay. And there's a question here about the makeup or properties of the tumor. And I don't know if typically the makeup is similar. We hear sometimes things about cystic tumors. So are there differences in the tumors once you get in there to sort of that make surgery and how you would proceed different once you are in the middle of it?
Yeah, of course. I mean, there are some tumors that each tumor is different. So some tumors have more vascularization than others, and so they are harder. Some tumors are a little more firm than others. And we take it case by case. And also, some tumors have been radiated in the past. That makes them a little bit more difficult. Of course, when they have a cystic component, there are some parts of the operation that may be a little easier, but then there are some other parts of the operation that are a little bit more complicated. So we take it case by case, and when we are in there, we want to know where the facial nerve is and follow the course of the facial nerve and preserve the structures that are very important for a good quality of life and a good success of the surgery.
Okay. And there's different sort of pros and cons with each different type of surgery. With translabyrinthine, the hearing is generally lost. Is that always the case with that one? And then so with retrosigmoid, there's this patient says that's been known to cause headaches. Why is that, and is that true?
Yeah, so it looks like with the retrosigmoid approach, the literature has shown sometimes that there's more prone to headaches than the other approach, and that's because we are basically manipulating, the cerebellum, and also we are exposing a little bit more of the meninges that are the coverings of the brain, and that just heals and can cause a little bit more headache and everything. So that's why I said earlier that it is thought, or usually, but it varies patient to patient, postoperative recovery after retrosigmoid can cause a little bit more headaches, and I think that's generally true.
Mm-hmm. Okay. And what about patients who experience regrowth after having radiation? When that happens, can radiation be repeated, or does it automatically need to go to surgery?
So it depends a little bit on the dose. It depends on the case, how big the tumor is. But usually if it has failed radiation, we would usually look at other options, including surgery. So, but it varies case by case. I cannot give a general recommendation.
Sure,
But
absolutely.
that's something that we discuss, of course, the need for surgery at that time.
Okay. And there's a question here about showing us on some of the models that you showed during your presentation, how Gamma knife might work to stop tumor growth. Is that possible on the within the presentation that you gave to illustrate that at all, or is it difficult?
So basically what Gamma knife does, the objective of Gamma knife is to stop the growth of the tumor.
Mhm.
So basically in the anatomy, in the MRI, subsequent MRIs, we see that the tumor, it may shrink a little bit, sometimes swells a little bit to shrink after that, but we don't see a significant change usually in size of the tumor. So the goal of Gamma knife would be to preserve things the way they are. So as the tumor, as long as the tumor does not grow, we call it success. So basically in the models I showed you, whatever the tumor is, we want with Gamma knife for the tumor to stay the same, so to not grow anymore.
Okay. And then, well, this is basically the same question. You said that you do address surgery after radiation if there's regrowth, that would potentially be an option, certainly, right?
Yeah, but of course, it's we'll have to see how the dose and when and everything, but usually it is the case. Yeah.
Okay. And if you're doing hearing preservation surgery, how do you protect the hearing during the surgery? How do you is it just because of the technique that you're using and the visualization that you have, or are you monitoring it? How do you protect it?
So we monitor the function of the eighth nerve to the
Mhm.
cochlear nerve. So if there's serviceable hearing, we usually can monitor that throughout the operation. But of course, there are some cases in which it's not possible. The bigger the tumor, the lower the success rate as far as hearing preservation options. So to my knowledge, there are two things that account for hearing preservation.
Mhm.
Number one is the anatomical distortion of the nerve. So if the tumor is very large, and even if there's serviceable hearing, but just manipulating the cochlear nerve, which is very, very sensitive nerve, that can make the function disappear. And also there are some small vascular structures that go to the inner ear that they may be contributing to the vascularization of the tumor. So I think it's critical if we can preserve them, to preserve them for hearing preservation options, but it's not always possible.
Okay. And I know we don't know a cause necessarily for acoustic neuroma, but do you have any insight on why these tumors occur where they do?
So we don't really know. I think it's very limited what we still know about vestibular schwannomas, but we know that for some reason they are the most frequent tumors to have schwannomas basically around that area. We have some schwannomas that are from the seventh nerve, some schwannomas, which is the facial nerve, some schwannomas that we have from the trigeminal nerve that we see sometimes, but a lot less frequently for some reason than vestibular schwannomas.
Okay. And for patients who have dealt with COVID, who are looking at potentially having surgery, is there a time that they need to wait before they seek treatment? Outside of getting over the symptoms and that kind of thing, is there some additional risk?
So I would say if you have been, it depends if there are any, post-COVID complications or any syndrome, and that has to be evaluated case by case. It's difficult to give a recommendation. Of course, in the acute phase of COVID, that would be completely contraindicated, of course, because when we put together a recovery from a brain operation or a large operation or a big operation like this, plus recovering from a virus like COVID, that could be potentially dangerous. But if if the patient has recovered completely from COVID, that would be, of course, up to the respiratory function that the patient has, and that has to be evaluated, of course, case by case.
Okay. There's a question here about a patient. If a patient has another schwannoma, so I guess it would not be a vestibular schwannoma outside of the cranium, is that medically relevant?
Well, of course, that has to be evaluated. And it has to be evaluated if that corresponds to two sporadic schwannomas, or that corresponds to a syndrome, if they are symptomatic or not. So, and looking for, probably screening for other possible schwannomas. So that has to be evaluated. I think that's a relevant part of the medical history, and that has to be discussed with the evaluating physician.
Okay, this question is very similar, and it's very specific, so I know you're not going to be able to give an answer necessarily, but if someone has had a prior brain surgery, and, but it's on the other side, and then has been diagnosed with a vestibular schwannoma, they're on watch and wait, but they're beginning to experience symptoms. Is the other tumor medically relevant, and is there a reason to move forward more quickly with treatment?
So it would depend if that newly diagnosed vestibular schwannoma is growing or not, and if it accounts for the new symptoms or not. But there's not a formal contraindication by having surgery on the other side of the cranium by not doing that surgery. So if the surgery is indicated, that has to be evaluated, of course. And if the symptoms change, they have to be evaluated again and have probably another imaging and be discussed with the treating physician.
Okay. Well, that covers all of our questions today. So I really appreciate your time and appreciate you staying to answer these questions. That was a very informative presentation and really unique. So it was something that I haven't seen before. So I hope that people found it very useful and helpful. I want to let everyone know we're done with presentations for today. We'll start back up tomorrow at 1 p.m. with Dr. Carlson and Dr. Link, who are going to talk about quality of life. And then we'll have two more later in the afternoon. These are all Eastern times at 5:30 and 6:30 p.m. You can find the whole schedule at on our website at www.anausa.org. And there's a web page slider on our homepage that will take you to the page where you can find all of the information you need on ANAwareness Week. We hope you'll participate, and thank you very much for joining us today. And thank you, Dr. Peris Celda, for taking the time.
Thank you very much. It's been a pleasure.
Thank you.